Okay, sure. Thanks, Namitabh. Uh, Good morning, everybody. We begin with one more edition. Probably it's a vacation edition, so we started a little late. We begin with one more edition of the IHRS DM-DNB teaching program, which was initiated last year and has somehow maintained its consistency thanks to the enthusiasm of the IHRS faculty, senior and junior from all over the country, who willingly responded to our invites and agreed to moderate. So those were the host faculty, and we had guest institutions. So these are number of teaching as well as private institutions in the country who boast of good EP teachers, arrhythmia teachers, and they thankfully created such programs which were focused on teaching the general cardiologist or the cardiologist in training, briefing him about the current line of thinking in arrhythmias and heart failure so that it is useful for a early career cardiologist in his practice and to a cardiology postgraduate probably in his exit exam. So that was the philosophy which the IHRS executive committee led by Dr. Yash Lokhandwala had in mind. And this is how we have been doing this program on the first Sunday of every month. My excuses for a slight delay in today's program. But first of all, let me say a very good morning and welcome the IHRS patron and a very, very senior teacher from this family, Dr. KK Sethi, who despite his busy schedule has immediately agreed to be a part of this today's program. And I think you will benefit a lot from him as well from Dr. Santosh Dora, who is a Sri Chitra alumni working in Mumbai at the Asian Heart Institute. Both of them will moderate today's session, which is focused on tachycardiomyopathy and pacing induced cardiomyopathy, both probably a little underdiagnosed by a non-EP cardiologist, and I'm sure there is a lot of learning to happen. Today's is a relatively short session. Shanmugh told me repeatedly that he has no cardiology postgraduates, but the two EPs that are part of today's program from the Vellamal Medical College in Madurai, Dr. Shanmugh Sundaram and Dr. Vadi Velu, are both have been excellent students and are now excellent EPs practicing in the country. And I'm sure they will bring good insights which will be helpful to the intended audience. Let me not spend too much time on the introduction and begin straight away by asking Vadi Velu to make his presentation. Dr. Velu, you are online?
Yes, sir, I am online, sir.
Perfect, perfect. So I think both of them have taken the liberty to present a case and follow it up with some didactic. May I request both of you that you might try to present a case and then discuss with the moderator and then do some kind of a review of the topic so that it becomes interesting. We need to use Dr. Sethi's presence well. He is a little short on time, but I'm sure his contributions will be helpful. Well, you can start with your presentation.
Shall I start with the case, sir?
Yes, please. That would be helpful. Yeah.
Okay, so this is a 24-year-old. Sorry, I would like to thank Dr. Yash Lokhandwala, IHRS President, and Dr. Ashish Nabha, sir, for giving this wonderful opportunity. So I will start with the case. The 24-year-old male episodic.
What are your slides are not yet up. Can you? Yes, sir.
We are seeing something from the computer of IHRS, which is giving some other, program or something. There is no slides there.
Acha. No. Well, your PowerPoint is on.
You have to share screen.
Share screen, yeah.
And then put the slides
okay,
there.
I'll stop share, then I will again.
Again, you do share screen and
share screen.
PowerPoint. Or keep that PowerPoint open and then you go to it.
Yeah, I'm doing that, sir.
Yes.
Yeah. Now is it okay?
Perfect. We can.
So, 24-year-old male, episodic palpitations on and off since last 1 year. Initially infrequent, now becoming increasing in nature and severity almost daily for last 2 months. He has associated dyspnea, which was not present earlier, now associated with EC fatiguity and lethargy. Echocardiogram showed a poor LV function and with mildly dilated left atrium and left ventricle. Also, the global hypokinesia was severe, but the LV wall thickness was preserved and there was no evidence of any scar, at least on echocardiogram. So this is the ECG. So I would. So ECG is showing a fairly narrow QRS complex tachycardia, which is quite irregular. And in between the episodes of tachycardia, we can appreciate the pauses as well, though it is not very significant, but tachy interrupted by sinus pauses. So how to proceed with this ECG and what is the diagnosis and how to?
So I think what you can see is there are, these are probably like an atrial tachycardia probably rather than purely atrial fibrillation. This is a sinus beat. There are sinus beats here. You have a patient with severe LV systolic dysfunction. Dr. Sethi, your comments, please.
Yeah, you can see a run of regular tachycardia in the chest leads with very clearly seen P waves there, which gives an impression that there is a long PR interval. The P wave looks upright in V1. It's quite irregular here in the first 5 or 6 beats that is there in the standard leads, actually lead 1, 2, and 3, and then terminates spontaneously with a pause, and then there is actually an atrial escape beat. It doesn't look like a true sinus, and then the focus of the pacemaker is changing from beat to beat in the lead AVL. So it's a very unstable atrium for some reason, and that is giving a variety of arrhythmias, and certainly either intermittently or in future atrial fibrillation is very much on the cards in this patient.
Yes.
Yes, sir. So at the outset, if a careful if a careful analysis is not made, such a careful analysis is not made, we would directly make a diagnosis of atrial fibrillation. But I would say even if diagnosis of atrial fibrillation is made and treatment is planned accordingly, this patient LV function will improve. But the main teaching point in this is if patient has some form of tachycardia and the LV function is down, and if there is a global LV hypokinesia with no evidence of any scar, then one should strongly suspect tachycardiomyopathy, because which is not uncommon in prevalence, but it is frequently underdiagnosed. So, so again here, though at the casual look, it looks like atrial fibrillation, but if you see in V1, the positive P waves are standing quite prominently and they are positive. So it means that these are left atrial ectopic P waves. So this should give a doubt of ectopic left atrial tachycardia. Sometimes atrial tachycardia masquerades as atrial fibrillation, especially when it is irregular. So we can it's when you put all the catheters in, it's very clear that it is not atrial fibrillation.
So it is Dr. Velu, before you decide to take him up for EP, it is probably important to let the students know that the atrial arrhythmia and heart failure is a two-way relation, right? It could be that people have heart failure from different causes like hypertension, diabetes, or previous infarction, and the risk of atrial fibrillation increases as the NYHA class worsens. And it is true other way around also that atrial arrhythmia may be the first thing to happen in a hypertensive, and uncontrolled these paroxysms, as in this case, might be the cause of LV systolic dysfunction, which is what you seem to be believing in this case.
Yes, so that's the most important thing. Sometimes it is a chicken and the egg story, but in majority of the patients, we can isolate or we can identify the cause. Is it tachycardiomyopathy or it's the cardiomyopathy that is causing the AF? But in some patients, it will be really difficult. But this patient is an younger. He was a 24-year-old male with no comorbidities at all, and he's having classical background history of on and off palpitations for last more than 1 year, and his heart failure symptoms were recent onset. So, and then the echocardiogram is suggestive of the global dysfunction rather than in isolated or segmented to some isolated ball like anterior ball or posterior ball. So this patient I will diagnose as tachycardiomyopathy rather than a primary non-ischemic cardiomyopathy generating atrial fibrillation. So because of the not only of the younger age group and the other diagnosis and other correlations, we should that's the most important teaching point here, is that we should not neglect such patients, saying that these patients are terminally ill and these patients should not be neglected a proper curative treatment. Because if we think this patient has a non-ischemic cardiomyopathy and atrial fibrillation or atrial tachycardia is the outcome of underlying cardiomyopathy, then the prognosis usually is very dismal. Even in such patients, if you do a proper rate control or a rhythm control, the LV function tend to improve, though not fully. In partial improvement in LV function can be seen in such patients as well. In fact, one of the common causes for worsening of already existing LV dysfunction is an underlying or a new onset atrial arrhythmia or ventricular tachycardia. So this patient, after undergoing proper management with medical therapy, his symptoms were not controlled. So his heart failure symptoms, after controlling his heart failure symptoms and after adequate rate control measures, he was taken up for EP study. And here it clearly sees there's a regularized atrial activity going on. Unlike atrial fibrillation, where there will be chaotic activity, which can be very clearly elucidated from the EGMs. And here again,
explain a little more, Velu, what is or where is the atrial activity and how you decided?
Yes, sir. These are the surface ECGs, 1, AVF, V1, and V6. And these are the coronary sinus electrodes. 1, 2 represents the distal EGMs, which represents the left atrial activity, whereas 9, 10 represents the right atrial or the right postoccipital region activity. And here the HIS catheter also shows
So in the coronary sinus electrograms, the big activity is the atrial activity, right? Because
yes,
coronary sinus is an atrial structure in the proximal.
Yeah, yes, sir. Yes, sir. This actually is the EGM taken during arrhythmia, because we can very clearly see even from the surface ECG, the V1 is clearly, though it is biphasic, it is clearly positive, whereas the sinus P wave will be initially, it will be positive, then it becomes negative. So here again, this you can see the radio frequency ablation catheter that shows clearly the signals. Here the ablation signals, it is way ahead than corresponding to the CS signals. So this was the site where this is the left atrial site, just near the junction between the LSPV and the left atrial appendage, where the good signals were seen and successful ablation was done. So this is the ECG after successful ablation. So the teaching point in this case was, so whenever you see a patient with recurrent palpitations and the documented ECG showing some form of tachycardia, it can be any form of tachycardia, either is SVT or VT or any arrhythmia arising from the conduction system, always do have a clear-cut suspicion of tachycardiomyopathy and do treat the underlying cause either with drugs or with DC cardioversion or with ablation. Then if you see an improvement, at least a partial or full improvement in LV function, then that means it is tachycardiomyopathy. So I will. With that case being the introduction part, I'll start with the proper presentation. I would like to acknowledge Dr. Yash Lokanmola, who is my mentor and a great human being and a wonderful prolific teacher. I also like to thank Dr. T.R. Muralidharan sir, HOD in Chennai, SRMC. And I would like to thank my ex-colleagues, Dr. Harshad and Dr. Neetu, who are from Holy Family Hospital, Mumbai. So we will be discussing these pointers: definition, epidemiology, etiology, classification, how to manage, prognosis, and some case-based illustrations. So we all know that what is the definition? Definition is either systolic and or diastolic ventricular dysfunction, defined as an ejection fraction less than 50%, secondary to rapid and or irregular myocardial contraction, but that should happen very frequently or that should be present in incessant manner, and that should get reversed either partially or completely after treatment of the underlying arrhythmia that is supposed to be the causative of the LV dysfunction. So it was described in 1913 in a young patient who presented with LV dysfunction and CHF with an underlying atrial fibrillation with a rapid ventricular response, and which was promptly resolved by control of arrhythmia. So what is the frequency? The frequency somewhere, I can say it is somewhere around 8 to 15% in overall arrhythmias. It's more common in supraventricular arrhythmias, and it's more common in atrial arrhythmias like atrial tachycardias, atrial fibrillation, atrial flutter. If you put all these together, atrial tachycardia, atrial fibrillation, atrial flutter, they form the most common cause of tachycardiomyopathy. In focal atrial tachycardia, it is somewhere around 8%, whereas in atrial flutter, it is around 14%, but these are from different series. So this is a rough estimate. Among patients with tachycardiomyopathy, Especially in children, the most common cause, somewhere 60% of the cause is due to ectopic tachycardia, and the second most common being the permanent form of junctional reciprocating tachycardia. Ventricular arrhythmias are less common, somewhere around 7%, and fascicular VTs, they are per se very less common in children. They are more common in adult population rather than children. So what is the mean time, or what is the average time from the onset of arrhythmia to the development of tachycardiomyopathy? Is that it can be as less as 3 days, or it can be as long as 120 days. So in overall, if you see, the most common cause for tachycardiomyopathy is atrial fibrillation, but in pediatric population, it is atrial tachycardia. But as I've said, if you put all the atrial arrhythmias together, atrial arrhythmias, they contribute the most common cause. And what about AVRT? AVRT form a lesser uncommon cause for tachycardiomyopathy, the most notorious being the septal accessory pathways, and especially other the appendage sites are notorious, especially in atrial tachycardia. If they are arising from the appendage sites, then they are notorious for tachycardiomyopathy, because these appendage sites are very difficult sites to access, either for ablation as well as for drug therapy, and they are incessant and they are drug refractory. And very lesser common causes being fascicular VTs and other form of idiopathic tachycardias, and inappropriate sinus node tachycardia, and high burden ventricular ectopic beats and persistent VPCs can also produce LV dysfunction. So these are the predictors of tachycardiomyopathy, either incessant or very frequent paroxysmal tachycardia, and younger age is more often associated with tachycardiomyopathy rather than the elderly age group. And a slower tachycardia, we all know that longer tachycardia cycle length, somewhere around 500 plus or minus 130 milliseconds, they are more prone to develop tachycardia rather than a fast tachycardia. Fast tachycardia, a short-lived tachycardia, is unlikely to cause tachycardiomyopathy rather than a slow, sustained, or an incessant tachycardia, or a recurrent paroxysmal tachycardia that is more likely to produce tachycardiomyopathy. And appendage sites are notorious and they are refractory as well. So what is the pathophysiology? What's happening basically is that frequently the systolic function reduces, and usually there is a diastolic dysfunction aspect. So both the LV end diastolic pressure reduces, but the end diastolic volume reduction is seen at the end stage of the disease. Sometimes some of these patients are labeled as refractory DCM and they are pushed to transplant, but if somehow tachycardia is suspected and curated, there have been case reports of saying that heart transplants have been avoided because of a simple ablation procedure once the diagnosis of tachycardia is suspected and pursued. So the LV diastolic pressure reduces, end diastolic volume reduces at a later stage, but the thing is, the overall LV mass does not change. Unlike in ischemic cardiomyopathy, where LV mass may be reduced, in this patient subgroup, the LV mass will not change much, but LV wall thickness may be reduced. Once the tachycardia is terminated, systolic function reverses, diastolic function remains abnormal for a long period of time. It's the abrupt recovery seen in systolic function, but diastolic function may take some time to improve fully. So what are the intricate mechanisms? We will not go into the details of this, but these are the putative mechanisms. Reduced sensitivity to beta-adrenergic stimulation, as well as the receptor density is also reduced. And with the sodium potassium ATPase, which is very critical for excitation contraction coupling, there is a change, both qualitative and quantitative change in the mechanism of action of sodium potassium ATPase activity, as well as the glycoside receptor level. And we all know that once this thing happens, the plasma natriuretic peptides, NT-proBNP, and renin activity and aldosterone levels all goes up. These are the three chains of heart failure mechanisms. And these chains, like natriuretic peptide, the renin angiotensin aldosterone axis, as well as the kinins, all these things get dysregulated in patients with tachycardiomyopathy, like similar to other forms of cardiomyopathy. And calcium handling of the heart also changes. Also, the tubules function also changes. So the excitation contraction coupling gets altered in an abnormal way. And there is one specific channel, that is swelling activated inward rectifying cation current, that also gets activated, abnormally activated. At least this is not tested in humans, but this is tested in canine models. And people are actively pursuing this as a molecular target for treatment in patients, not only in patients with tachycardiomyopathy, but also in patients with other forms of dilated cardiomyopathy. So one thing is very important is that the myocardial blood flow reserve is reduced in patients with tachycardiomyopathy. Though the overall blood flow, the myocardial blood flow is not reduced, unlike in patients with ischemic cardiomyopathy, where the main mechanism is being the reduced myocardial blood flow. In patients with tachycardiomyopathy, it is the coronary flow reserve that is reduced rather than the myocardial blood flow itself. So again, there are two important things. The expression of CD68, which represents macrophage-mediated inflammation, is quite predominant in patients with tachycardiomyopathy, whereas in patients with other forms of myopathy, especially ischemic and non-ischemic cardiomyopathy, there is T-cell-mediated immunity that is more common, whereas here it is macrophage-mediated inflammation, and the expression of MHC2 molecules is higher in patients with tachycardiomyopathy. So what about fibrosis? Fibrosis is severe form of fibrosis seen only in 30% of the patients, whereas mild to moderate fibrosis is seen in majority of the patients. This is the reason for either a full or a partial recovery in LV function, unlike in patients with ischemic cardiomyopathy, where permanent form of irreversible fibrosis is seen in more than 90% of the patients. Also, at the intracellular level, not only it's tachycardia, because we may think that it may not be a true entity. Because of the tachycardia, the assessment of LV function is falsely low, we may think, but the electron microscopic findings by Mueller et al. Has very clearly shown that even in patients with tachycardiomyopathy, there is loss of myofibrils and there is disruption of intracellular structures, thereby proving this is a separate form of cardiomyopathy and it is not just a mere false perception of low EF due to increased heart rate, right? And here, these are the things which shows abnormal fibrosis, a lesser degree of fibrosis and loss of myofibril components. And here in tachycardiomyopathy, the inflammation and fibrosis is more common at intercalated disc rather than at the other forms of cellular levels. It is the junction between the two cells, that is the intercalated disc. The macrophage mediated inflammation fibrosis is more common at the intercalated disc level rather than the other forms of the cell. So it is mainly macrophage dominated cardiac inflammation. So here you can see the fibrosis score is higher in ischemic cardiomyopathy, followed by dilated cardiomyopathy, whereas in tachycardiomyopathy, in 30 to 40% of the patient, it is milder to moderate forms of fibrosis rather than severe fibrosis. So this, so coming on to the classification, it is this Fenelon et al. In 1996 classified it pure and impure type. What is pure? Pure is that this is it's completely attributed to tachycardiomyopathy and there is no underlying structural heart disease. What is impure? Impure is patient has already underlying LV dysfunction, either due to ischemic cardiomyopathy or due to dilated cardiomyopathy. If it is an impure type, the superadded arrhythmia may worsen the LV function, and if you control that arrhythmia, then the LV function recovers, but only complete. It's not a complete recovery; it's only an incomplete recovery. So what about the newer classification? This is from the Dr. Ayash group, very recently published in 2021, where they have described it. They have studied over 50 patients over a period of 2 years, where they have given a classification of classical tachycardiomyopathy and a partial tachycardiomyopathy, and there is one interesting entity known as exaggerated tachycardiomyopathy. So what is classical is that complete recovery happens in 3-month period. Partial is that only partial reversibility happens in 12 weeks period. Exaggerated TCM is nothing but immediate improvement. Even if you just ablate or if you do a cardioversion and if you assess the LV function immediately, you can see an immediate improvement followed by a variable course thereafter is known as exaggerated tachycardiomyopathy. Though it is a rare phenomenon. This is from the same study. You can see the sample size is 50 and the mean age is here 53 years. Whereas if you look up other published literature, majority of the literature is in relatively younger population. But here, this is an Indian setting where the mean age is somewhere around 53 years, and the comorbidities are frequently common. And the most common presentation being the palpitation, and the least common presentation is syncope. So some of these patients can present with syncope because we know once LV dysfunction sets in, and this patient may not tolerate arrhythmia as before. And majority of the patients, they presented with either class 2 or class 3. And again, here the most common arrhythmia is atrial fibrillation, followed by atrial tachycardia and atrial flutter. And ventricular tachycardia, as known, is very less common cause. And you can see that there are different forms of treatment modalities have been used. either with cardioversion and or antiarrhythmics, pulmonary vascular isolation in patients with atrial fibrillation, and other RF ablations for atrial tachycardias and for accessory pathways. And here we can see the mean LV ejection fraction is 26%, whereas immediate post tachycardia, the LV function has improved a bit, but p-value was significant. But if you see at 3 months follow-up, there is a remarkable dramatic improvement in LV function all the way back to 50%. This is very important. And this is again the same slide. This is showing classical versus partial versus exaggerated cardiomyopathy. In exaggerated cardiomyopathy, there are only very few patients. But again, the most common cause being the atrial arrhythmias. So the other classification being arrhythmia induced, the sole cause being the LV dysfunction being the arrhythmia. Arrhythmia mediated is the arrhythmia simply exacerbates the ventricular dysfunction. So almost all the classification, they try to say that if the patient already has an underlying LV dysfunction, then the LV function recovery will not be complete, and they have a worse prognosis when compared to patients with no underlying LV dysfunction to start with. Here we can see one of the things we have to suspect. If a patient with LV dysfunction has a higher heart rate always, then we should suspect tachycardiomyopathy. We see here the mean heart rate in tachycardiomyopathy is always higher when compared to other forms of cardiomyopathy. And improvement in LV ejection fraction, as we all know, it's always higher in patients with tachycardiomyopathy. This is coming on to the cases here. This is another case again. In this patient, atrial tachycardia was masquerading as an atrial fibrillation. Is 54-year-old male, hypertensive, frequent paroxysmal palpitations since 1 year, and 1 episode of near syncope. And we'll go to the ECG. This is the ECG. Again, here ECG shows an irregular form of tachycardia. It looks like a white QRS complex, but it's not a white QRS complex. If you carefully see, it's a narrow QRS complex, or you can say it's a narrow QRS complex with LVB aberrancy. And if you see here, the inferior leads are 2,3 A wave. You can pick out some form of discrete P waves, thereby ruling out atrial fibrillation. Sometimes in patient with atrial fibrillation, you get a flutter-like activity in V1. That is due to because V1 is placed very close to right atrial appendage, where even in patient with atrial fibrillation, the atrial activity is organized in right atrial appendage. So if you get an isolated flutter-like activity only in V1, not in other leads, then it's only due to atrial fibrillation. We should not call that as atrial flutter fibrillation or fibrillation flutter. But if you spare V1 and if you get such activity, if you can see some discrete P waves or flutter-like waves in other leads as well, then it is flutter or atrial tachycardia in that patient. Again, you can see here, actually what's happening is ectopic P waves are seen here. This is a regular tachycardia. At times it is regular, at times it is not regular, and at times it is having an aberrancy. So again, it is mislabeled here as ventricular tachycardia. Actually, it is not ventricular tachycardia. It's actually an atrial tachycardia with aberrancy, right? So this is the EGM of this patient, clearly showing organized atrial activity going on. And if you, the distal EGM with the ablation catheter is showing the ectopic atrial wave mapping very earlier than any of the CS thing, or even earlier. If you compare the surface P wave, it is way earlier than the surface P wave. And the distal EGM is earlier than the proximal EGM. And also you get a good unipolar EGM. That means this is a good area to go. And this is one of the cases of mitral annular atrial tachycardia. So where successful ablation lead to reversal of cardiomyopathy in this patient. So in the superior mitral annular region is a very specific region, which is very, very uncommon. It spreads from 11 o'clock to 2 o'clock. And the interesting points is that atrial tachycardia from this region may mimic atrial fibrillation. And it is somewhat not response therapy to medical therapy is not that great. So we may need to do ablation in such patients to bring in a better response and reversal of cardiomyopathy. This is the fibrous trigrone region. We can see here, somewhere here lies the mitral annular region, where mitral annular MAT, we call it as mitral. It is not multifocal atrial tachycardia, it is mitral annular atrial tachycardia in this patient. As we all know, these are the other sites of atrial tachycardia. So we have to, mapping in atrial tachycardia is difficult. It's unlike in SVTs. Atrial tachycardia is one of the difficult tachycardias. Sometimes many times you require a 3D mapping system to achieve a better response or a better success rate. And to reduce the recurrence rate, you need a 3D electroanatomic mapping, because sometimes the tachycardia gets terminated and you may not go to that site specifically. To go back to that site, you need 3D electroanatomic mapping. This is the case I've already discussed. So I'll skip this case. I'll go to the other case. And what are these are the basic electrophysiological characteristics to suggest, to favor and against tachycardia. We all know that no age delay is necessary for initiation. And we know when the cycle length, when there is a tachycardia cycle in the oval, the initial HH oval will be driven by AA. That is, initially there will be the change in AA length, and that drives the HH change. Whereas in other tachycardias like AVRT and AVNRT, it is the HH change that drives the AA change. Whereas here the reverse, and there is an absent VA linking. That is, if you take B to A interval, it may differ from one cycle to the other cycle. And in entrainment response, you get what is BA AV response. Whereas in other forms of SVT, you get BAV response. What are the characteristics against? If tachy terminates in the AV node or tachy terminates in A, then it is strictly against tachycardia. And VAV response again goes against atrial tachycardia. And his refractory VPC affecting or terminating the tachycardia goes strictly against atrial tachycardia. You can see this is a one EGM to show VAAV response. So here entrainment has began, tachycardia is going on. We are pacing the right ventricular apex, and we are pacing at 20-30 milliseconds slower than the tachycardia, faster than the tachycardia, and good entrainment is seen upon upon termination of the ventricular pacing. We can see the tachycardia continuing, and what we see is this is the V, that is the QRS, and this is the HL AA followed by V. This is very classical of atrial tachycardia, but we have to be very careful about the pseudo responses which can be seen in patients. So, these are the risk factors I have already described: longer tachycardia cycle length and slower ventricular rate. On appendage sites, they are notorious for producing tachycardiomyopathy in patients with tachycardiomyopathy. So median, this is one of the largest series where they have studied, and the median age and diagnosis is 7 years. Tachycardiomyopathy is as high as 30%, and resolution of tachycardia was seen in around 90% of the patient. And once the arrhythmia is controlled, like in the form of antiarrhythmics, which could do the job in 70% of the patient, whereas catheter ablation was permanent, and the success rate was around 80%. What about the recurrence rate? The recurrence rate was higher with conventional mapping. It was around some 30%, whereas electroanatomic mapping, it is as low as 16%. But for senior electrophysiologists, this may not be true. They may even do the procedure without electroanatomic mapping, and their success rates as well as the recurrence rates will be good as compared to electroanatomic mapping. And this is again one of the interesting reports reported by Dr. Shomu Bora and Dr. Esh way back in 2011, where we all know that ivabradine has been approved for management of tachycardia, but in some of the patients with atrial tachycardia, ivabradine can be effective because there has been mechanisms where in patients with automatic atrial tachycardia, funny current may have a role in propagation of this tachycardia. So in this patient, ivabradine controlled atrial tachycardia, but when ivabradine was discontinued in this patient, tachycardiomyopathy, the atrial tachycardia returned, tachycardiomyopathy also returned. So this patient was taken up, and successful redo ablation of the atrial tachycardia was done at the junction of LAA and LSPV. Once the successful ablation was done, tachycardiomyopathy was gone, and the atrial tachycardia did not occur. We can see here the left is a regular narrow QRS tachycardia, and here this is after ivabradine, the patient reversed to sinus tachycardia. And we all know that in adult, atrial fibrillation is one of the very common cause for tachycardiomyopathy. You say whatever, either for complete or for partial cardiomyopathy, it's one of the very frequent causes. You can see during ablation, you can see EGM showing PV potential, and after ablation, this PV potential is gone. This is again one of the the most common atrial arrhythmia in elderly being atrial fibrillation. This is a 78-year-old male, CKD, with a lot of other comorbidities, paroxysmal atrial fibrillation on treatment, and he of late presented with heart failure symptoms in the form of worsening shortness of breath, ARRHYTHMIA, and some of the patients may even present with volume overload like bilateral fetal edema, all those things. The ECG quality may not be good, but it shows atrial fibrillation with rapid ventricular rate. And here you can see the LA is mildly enlarged, and overall the LV function is not good. The EF was 30% in this patient, and it's a global LV hypokinesia was seen in this patient. And tropi was elevated, and the NT-proBNP was sky high. And there was moderate MR, moderate TR was also there. And again, this is a plaques view showing LV dysfunction, but you see overall the LV wall thickness is good. After 9 days of treatment with rate control measures with beta blockers and digoxin, you can see the drastic difference and the dramatic improvement in LV function. Also, the MR has come down. The LV ejection fraction has improved from 28 to 45%. So this is at presentation. So this is the 2D echo at different views at the time of discharge, where we can see a near normal LV function. This is another patient, 29-year-old male with incessant tachycardia. Ejection fraction was 40%. Again, this is a very classical ECG. Here we see this sawtooth flutter waves, making this is a case of atrial flutter with tachycardiomyopathy with LV dysfunction. We all know that this can be controlled with antiarrhythmics, DC cardioversion, or ablation. Atrial flutter is one arrhythmia which is refractory to antiarrhythmics. Patient may not tolerate the dose of antiarrhythmic needed to suppress. So either DC cardioversion or ablation will do wonders in such patients. Again, this is the intracardiacs showing this is an halo catheter. This is the catheter, halo catheter, that is placed in the right atrial region, whereas it maps the whole of the tricuspidal annulus region. And here will come the coronary sinus catheter, which maps the CTA region as well as the left atrial and the mid-septal region. This is the ablation pointer. This is the ablation catheter, which is kept in the CTA region. And here we can see that starts from the distal halo and it spreads to the proximal coronary sinus, thereby suggesting this is a counterclockwise atrial flutter. Once a diligent mapping and atrial flutter ablation is done, we can see here the left showing atrial flutter. Once an ablation is done, you can see it's terminated to a sinus rhythm. And invariably, these patients' LV function improves, and this patient will do really well in the follow-up. So again, this is the electrodynamic mapping showing the CTI, and these chocolate burns are nothing but here you can see after successful ablation, the tachycardia terminates. And this is the propagation mapping, though it is not very clearly showing the slow conduction region in the CTI or in the roof region. There have been, so though we do not require for a very classical atrial flutter, sometimes many times we may not even require electrodynamic mapping. But having said that, sometimes atrial flutter will have two components, what we call it as dual loop tachycardias, where electrodynamic mapping will come very handy, or in forms of scare-induced atrial flutter, or in forms of atypical atrial flutter that are very difficult to treat with conventional mapping. With electrodynamic mapping, it may become a little bit more convenient, though we all know that atypical atrial flutter is very difficult to ablate as well, and recurrent rates are very high. This is another patient, 40-year-old patient, presenting with rapid palpitations and with shortness of breath. Again, if you see, this looks like a narrow QRS, but if you see very carefully, it is somewhere around 120 milliseconds. And the V1 is predominantly positive. And you can see the V6 has a deep S wave. And we know the 2-3 AVF, they show predominantly negative QRS complexes, and AVL and AVR is showing upright QRS complexes. And you can see very clearly in the lead 2, there is a fusion beat seen here. So with all these things, we can, and there is some form of AV dissociation as well. If you see very clearly, we can see some form of P wave is coming here, but there is no P wave here. So with all these things, we know that this is nothing but the ventricular tachycardia arising from the posterior fascicle, left posterior fascicle. And this is one of the notorious tachycardia that can present with LV dysfunction, tachycardia myopathy.
Oh, I see.
Again, here the left infroseptal region, basically showing the early. We can see here this is the fascicular potential during sinus rhythm And this is some, we call it as peak diastolic potential during tachycardia. And during successful ablation, tachycardia terminates. Again, fascicular tachycardia is one of the difficult tachycardias to ablate because it may, if you are lucky, it gets terminated within 45 minutes. If you are not lucky, it may take long hours. Sometimes we do not know whether it is papillary muscle or fascicular tachycardia, then we get stuck. But in such patients, even if you do a partial ablation, the arrhythmia burden comes down, and calcium channel blockers, they do wonders, and patients invariably improves, and they'll do better, because this is one of the tachycardias arising from the structurally normal heart, and patients do invariably well. Again, this is one of the out-of-the-box solution to tachycardiomyopathy. This is an 84-year-old gentleman, old inferior wall MI, who has got stents in 2015. Presents with heart failure symptoms with ejection fraction of 25%, and he had history of past tuberculosis with AKT-induced hepatitis, and he has some form of liver dysfunction as well, even with raised OTPT, and he has repeated admissions of recurrent heart failure over the years. And this time he presents with fever, with heart failure symptoms, with generalized weakness. And what we see here in the ECG, here we see frequent form of VPCs are seen here. Though in the left panel, we see single ECG is the most predominant form. In the right ECG, we see VPCs with different forms. So this patient, again, in such patients, though this patient is a known case of LV dysfunction, known patient with old inferior wall MI, now presenting with some febrile illness, now presenting with heart failure symptoms, with frequent VPCs, we have to have at least a partial tachycardiomyopathy or impure form of tachycardiomyopathy, where patient may have underlying LV dysfunction, but this VPC is now causing worsening of LV dysfunction, right? And this patient started having NSVTs, and he was symptomatic during NSVTs. So, and he was not responding to the conventional form of drug therapy to suppress the VPCs, like in the form of xylocort bolus and infusion, beta blockers and mexiletine. Cotton was not given in form of in view of acute febrile illness and with hepatitis with raised OT and PT. And atropine and isoprenaline was used to increase the sinus heart rates, but it failed because this patient also had sinus bradycardia. Because sometimes when you try to jack up the sinus rate, this VPCs may get suppressed. So in this patient, what was done is a simple CS catheter was placed, and sinus rate was, the atrial pacing rate was increased to a rate of initially more than 120 beats per minute. And that was noted to reduce the VPC burden, because he was a very frail elderly male in this patient. Taking this patient for VPC ablation, all those things may be cumbersome, though it is undertaken very frequently in Western settings. In our settings, patient may not afford, and patient may be too frail in such setting, and especially in acute febrile illness, we may not do all those things. So when the heart rate was kept at 120 to 130 beats per minute, his VPCs disappeared, and his LV function improved, and his heart failure symptoms improved. And ultimately, this patient received an AAR permanent pacemaker, and the lowest heart rate was set at 100 per minute. And this patient did well. The NSVTs disappeared. The PVC's burden has become significantly reduced, and ejection fraction has improved to 40%. And he was discharged with the basic medications, because he was thought to have some form of underlying sinus node dysfunction as well, because he had sinus bradycardia. So we could not use these agents without an underlying pacemaker. So pacemaker in this patient did two things. One is we can confidently give drugs, and the other thing, if VPC's burden increases, we can increase the atrial pacing rate to suppress the VPCs as well. So what about the reversal of cardiomyopathy? Successful ablation can be done in 90 to 95% of the patient, and invariably the LV function improves in majority of the patients with reduction in LV end diastolic diameter, with reduction in biomarkers, and ventricular function normalizes in almost 90% of the patients over a median period of 3 months. So this is again, this is an echocardiogram showing before ablation in a patient with tachycardiomyopathy with atrial tachycardia. We can see the heart rate is faster, unlike in patient with dilated and ischemic cardiomyopathy, where even at low heart rates, you will have severe LV dysfunction. Here, you can see this heart is contracting at a faster rate. And this is an after ablation. You can see the heart rate has come down, the sinus rhythm is seen in the ECG, and the LV function has improved dramatically. So to compare before and after, we can appreciate very well the improvement in LV function. So what about the prognosis? If the LV ejection fraction improves more than 40%, then these patients invariably do really well. But despite ablation or despite control of therapy, despite control of heart rate, if the LV function persists to be less than 40%, then they have threefold increase in mortality rate. So this is the most important thing in prognosis, but majority of these patients do really well when compared to ischemic cardiomyopathy and dilated cardiomyopathy. So these are the take-home messages. Tachycardiomyopathy is not, I will say, it's not uncommon. If you think and if you suspect in some subset of patients, then you may make meaningful improvement in altering the outcome of such patient. So other causes should definitely be ruled out, like toxic cardiomyopathy, because in some patients, toxic cardiomyopathy patient may present with both tachycardia and LV dysfunction. And then again, as Dr. Nabasar initially told, patient with dilated cardiomyopathy may present with atrial fibrillation at the end stage. Then control of arrhythmias is more the pivotal pivotal role in controlling the heart failure is not the neurohormonal blockade, like we say the four pillars of heart failure, what we call beta blockers, aldosterone antagonists, ARRHYTHMIA, SGLT inhibitors. These are not going to be the pillars of treatment in such patients. The main pillar in treatment of such patients is treating the arrhythmias. I will say the three pillars being the drugs, DC cardioversion, and ablation. These are the three pillars in this subset of patients. And reversal of cardiomyopathy is seen in majority of the patients, at least partial reversal is seen. And this is one of the very good and treatable causes of cardiomyopathy. But after ablation or after drug therapy, if there is a recurrence of arrhythmia, then the devil returns. Tachycardiomyopathy invariably ensues in such patients. So with this, I will end my talk and we'll have some discussions.
Sure. Thanks, Dr. Velu. I think a very illustrative and detailed presentation. At least I understood that there are a number of factors that lead to tachycardiomyopathy. It is the fast rate, it is the irregularity of the arrhythmia, like in atrial fibrillation or PVCs. It can be the AV dissociation, which can be contributing, and sometimes in supraventricular arrhythmias, it can be the aberrancy that can contribute. Number of factors that can make a tachycardiomyopathy, and all sorts of arrhythmias are prone to it. Suspicion and diagnosis is important, and you clearly outlined the three pillars. Dr. Sethi, are you available for the discussion? Or Dr. Dora may take this up further then.
Yeah, it was extremely very well discussed by Dr. Badivelu. I think he covered almost all kind of tachyarrhythmias which lead into tachycardiomyopathies. And again, that what caused first, whether tachycardia caused cardiomyopathy or cardiomyopathy caused tachycardia, whatever it is, I think the importance to be given to the tachycardia, and we have to treat the tachycardia in either cases. In case of tachycardiomyopathy, the heart pumping or ejection fraction or LV function is almost going back to normal. In the other case, cardiomyopathy, again, later on secondary tachycardia also, the patient will be going to benefit when the tachycardia is controlled. So in either cases, the tachycardia has to be managed very well with whatever means, by medications or ablations. Or the another thing that I would like to focus on, and basically, as you told, the atrial fibrillation is the most important cause for tachycardiomyopathy. You described many cases of atrial tachycardia and ventricular tachycardia. In these cases of atrial fibrillation, especially when patients comes to us with a low ejection fraction and maybe a single ECG or two ECG showing ventricular rate is well controlled. But when you do a Holter study or long-term ECG monitoring study, you see that in many instances, the patient may be having very fast ventricular rate. In these cases, we're wondering whether to treat, how to treat these kind of cases. If you go on increasing the rate control drugs, the patient might be developing into significant brady at times, which will limit us using the rate control drug effectively. In these cases, another mode of treatment is probably to think about CRT or conduction system pacing, and probably later on doing AV node ablations. So that is one of the way to treat, especially when the atrial fibrillation difficult to ablate atrial fibrillations leading into cardiomyopathy with LV dysfunction. Otherwise, very well discussed, Dr. Badivelu. I think we are running short of time, started a little late. We have another topic in hand. Over to you, Dr. Assis.
Yeah, sure. I mean, we can go with the next presentation. Only thing, PVC-induced cardiomyopathy, Dr. Dora, can you say a few things about what burden of PVCs and things like that one should suspect a PVC-induced cardiomyopathy? Which kind of PVCs are more prone to develop that kind of tachycardiomyopathy?
Yeah, again, that is a very important thing. I think many of the patients most of the patients, of course, with
so nowadays we talk of this terminology of arrhythmia burden. So can you a little bit talk on that?
Yeah. So arrhythmia burden, as classically as we saw that, of course, the next topic is Dr. Shanmuga will be talking what is the percentage of RV pacing is going to cardiomyopathy. It is something like that. You know, how much of ectopics is going to develop into cardiomyopathy. So classically, it is around 15 to 20%. If it is more, the pacing burden or the arrhythmia burden, the ectopic burden, that might give rise to cardiomyopathies. So, but the higher is the chances more developing into cardiomyopathy, the lower is less chance of developing into cardiomyopathy. However, when the classically 15 to 20% of arrhythmia burden is probably going into, the patient might get into cardiomyopathy. But with the lesser burden also, I think there are many subtle indications of patient developing into cardiomyopathy, either symptom-wise or when you see serial dimensions of the left ventricle, if you see it is getting increased, or do some investigations like NT-pro, BNP, and also like that, it might be in the increasing stage. Those are the indicators that the patient is getting into cardiomyopathy, subclinical variety of cardiomyopathy. Even if the patient is not very much symptomatic of heart failure, but patient might get into that stage, so they may need attention to treat those kind of cases.
Sure. As you rightly said, we are will be short of time if we don't stop on this here. Let us invite Dr. Shanmugh Sundaram to deal with an kind of similar topic, in the sense that something that is not very commonly dealt with by a non-EP cardiologist and probably not entirely grasped so easily. This time we are discussing pacing-induced cardiomyopathy and what new solutions we have to take care of such a situation. Dr. Shanmugh, please.
Thank you, sir. At the outset, I would like to thank Yashar and Naber sir for giving us this opportunity. Let me share my screen. Is it visible, sir?
Yes, very much. Please go ahead.
Let me start with the case scenarios. So I'll be providing two different cases regarding to the topic. So the first one is regarding a 56 years old gentleman who was diabetic hypertensive with recurrent syncope due to complete heart block. So he underwent pacing elsewhere in the month of June last year. So the RA, he received a passive fixation lead at appendage, and for RV, he received an active fixation lead at RV apex. And in February, he developed exertional dyspnea, and in the March, he has to be hospitalized for his heart failure symptoms. The echo then showed a moderate LV dysfunction with global hyperkinesia. Ejection fraction was somewhere around 35. He had some mild mitral regurgitation. So ECG was okay. He sensed RV pace, and the QRS duration was roughly around 150 to 160 milliseconds. And his NT-proBNP levels were very high. So a provisional diagnosis of pacing-induced cardiomyopathy was made with an EF of 35%, and in view of frequent heart failure hospitalization, so he was referred to our institute for further management.
The second case is almost a similar one, but with a different perspective. So he was an 80 years old doctor who was a diabetic hypertensive. So he had undergone a bypass surgery in 2013 for triple vessel disease. The very next year, he developed complete heart block with a mild LV dysfunction. The EF was 45%, and being a doctor, and they wanted to give a best therapy, so they advised CRT, and the procedure went for a long time, and despite repeated attempts, they could not complete the CRT procedure because of probable poor venous anatomy. And they came out with a simple DDD with the RV apical pacing lead. So as per his son, who's also a doctor, urologist, he said the next day he had undergone a lead repositioning for a probable atrial lead dislodgement. So over the years, he started developing a worsening LV function, and he presented to us last year with an EF of 30%. He had on and off episodes of atrial fibrillation, for which he was already on Novak. He had associated comorbidities in the form of obstructive uropathy, some lung sequelae due to COVID-19, and recurrent heart failure hospitalization. Many times I had to manage him through phone in their own hospital, which is 100 kilometers from our city, for his cardiogenic shock. So he came to us in this year, in the month of March, I think, with the battery reaching ERI. So this is his fluoro showing atrial and ventricular leads. As expected, there was some difficulty in positioning the atrial lead. So that is the reason for, probably that was the reason for the lead dislodgement, which happened on the next day. And they had done some repositioning, and luckily the lead stayed there and the atrial parameters were good. And this is a CCG, and probable diagnosis of pacing worsened cardiomyopathy in a pre-existing LV dysfunction was made. And we had to decide about further management. So there is two clinical scenarios where one case purely related to pacing, and pure pacing is the one which actually the culprit one for producing this cardiomyopathy. In the second case, in fact, in a patient with a pre-existing cardiomyopathy, pacing has actually worsened the underlying cardiomyopathy. So it's open for discussion. Probably we can have some discussion before I go into the topic first.
Yeah, Dr. Shanmugam, how was this? The atrial lead was functioning well at the time of last.
Yes, sir. Atrial parameters fine. Atrial parameters were fine. So the R wave was somewhere around 2 to 3 millivolts, and the threshold was 0.75.
Right. Yeah. And this patient to begin with had left ventricular dysfunction. I think the ejection fraction was 45 to 50%.
Exactly,
and,
sir.
yeah. And when the patient develops complete heart block and with a reduced ejection fraction that is less than 50%, then the ideal thing was probably CRT. And however, it was tried, but it could not be done. And the patient went into, had to go with the dual chamber pacing. The next best thing, of course, as of now, we will think about the conduction system pacing, but in 2014, probably the things were not that developed. However, the patient had RV lead at the septal position or in the apical position?
Apical position. Both these patients had an apical pacing.
Yeah. Of course, I don't feel there is too much of difference between apical position and septal position, because in either cases, most of the time the QRS is really wide. If you see in many cases, of course, in some cases maybe the septal pacing, the QRS may be slightly narrow, but in most of the cases it is really wide. So,
Dr. Dora, I was going to ask you: is there any equivocal evidence of other site spacing in the RV, endocardial RV pacing, making a difference?
You are talking about
yeah, RV mid septal or RV outflow. Does it really help, or
no? I don't think. Of course, there are not many studies pointing into that.
Yes.
But if you see in my personal experiences, in many cases, if you go by the QRS width, I don't see there is significant difference between septal and apical. Of course, the apical will be slightly more, the QRS width wise, but the QRS remains wide. So that is aberrant conduction type, aberrancy of the electrical aberrancy that persists at any site, except the conduction system pacing probably.
Yeah. One more discussion that I want to have before Shanmugh proceeds is that sometimes patients have an intermittent complete heart block. And if you program to a continuous pacing, continuous ventricular pacing, that can lead to such cardiomyopathies. Can you delve a little bit on uh, the features available to reduce the ventricular pacing when it is not required?
Yes, sir. Actually, exactly. That is going to be my next slide. In fact, to
Sure.
how
Anybody
to
of you can. Yeah.
So obviously, in a patient with an intermittent AV conduction, the idea is to get the utilization of the native AV nodal conduction. So a lot of companies, they have their own algorithm. For example, Medtronic have this MEP algorithm, which is otherwise known as managed ventricular pacing. So where you can actually program the AV delay to look for native AV conduction. So for example, you program the paced AV delay as 150 or 180. So there is one window called MEP where you can open it up. And you can always tell the pacemaker to look for native AV conduction by prolonging the AV interval for some cycles. So the pacemaker will actually prolong the AV interval for some cycles, and it will look for AV conduction. So once it sends some ventricular impulses, it will inhibit itself from giving a pacing spike so that the native AV conduction will activate the ventricles. In that way, native AV conduction can be activated just by simple prolongation of the AV interval intermittently. So if it senses that ventricular electrogram, then it will not give further pacing spike for some moment until a dropped V is sensed. So for example, after 2 or 3 minutes or after 1 or 2 hours, if the pacemaker senses some sort of dropped V or a ventricular electrogram, then it automatically goes back to an original DDD mode where it is going to give its own ventricular pacing impulses. So this, every company have their own algorithm. For example, VSP in St. Jude and MEP in Medtronic, and Boston has its own algorithm. So in that way, actually can reduce the pacing burden in those patients who are having intermittent AV block. But for those patients who have a committed pacing with a 100% AV block, in those cases, I think this managed ventricular pacing or whatsoever algorithm is not going to give added benefit.
Yes.
So I think I'll go ahead with the introduction about this pacing-induced cardiomyopathy before I could conclude by describing how we actually manage these cases. Right. Of course, like Naba sir was discussing how to manage these cases, you have to look for reversible causes. There is no dictum that these patients should not have an underlying associated ischemia, though they could have looked at it whenever the pacemaker was implanted. But always look for some reversible causes to look for this. Even recent COVID might have precipitated it. So if possible, if you have an opportunity to cardiac MRI to look for coronary anatomy, always do it to rule out a reversible cause. Optimize the medication that, like Vadivel was talking. So give the essential heart failure medications. Try to reduce the ventricular pacing. Make use of the available algorithms. Each and every company, they have their own algorithm. Of course, if you have made a diagnosis of pacing-induced cardiomyopathy, so all these things will not work. It's just going to be a palliative treatment. Obviously, you need to go for a pacing upgradation. So upgradation, till so far, the guideline says go for a bi-V pacing upgradation. What will you do to the whole lead? So that we'll see what to do. And of course, the novel strategy, conduction system pacing, where you can either pace the his bundle or left bundle, is going to give wonderful response in this group of patients. So in the next 15-20 minutes, I'm going to talk about this pacing-induced cardiomyopathy. So we know the deleterious effects of RV pacing, Dora sir was telling. So an RV apical, or for that matter, septal outflow tract pacing is after a myocardial activation. So that is going to produce dysynchronous or asynchronous activation of the left ventricle. So on the long run, there will be some electrical and structural remodeling, which is going to produce LV dilatation, LV dysfunction, recurrent heart failure hospitalization, atrial arrhythmias, and obviously these will put the patient at risk of increase in mortality and morbidity. Of course, trials have consistently showed that once the pacing burden goes up, for example, either 40% or 20% cutoff they have taken. So once it crosses the pacing burden, so these patients are at risk of developing recurrent heart failure hospitalization, and of course, increase in the incidence of atrial fibrillation. Definitions, a lot of definitions are available. Based on the definition, incidence also varies. So in fact, there are 3 commonly used definitions. One is an EF of less than 40% if the baseline EF is more than 50, or an absolute reduction by more than 5%. The second definition, it's an EF of less than 40 if the baseline EF was more than 50, or an absolute reduction of more than 10%. Third definition, an absolute reduction of more than 10%, irrespective of the baseline ejection fraction. So based on the definition, the incidence varies. It may be varying between 9.3% to 40%. Of course, clinically, you can see 10 to 20% of the patient where you can document an EF of less than 50%. But remember, this is just a tip of an iceberg. The structural and electrical remodeling would have occurred in a lot more number of patients. And in fact, histopathological studies, they have shown that this normal myocardial function can be documented as early as 48 hours after RV apical pacing. So this in turn is going to produce an increase in LV filling pressures, increase in BNP level. Of course, this will be translated into increase in heart failure hospitalization and atrial arrhythmias, probably with a borderline ejection fraction. In a patient with a pre-existing cardiomyopathy, of course, you'll be able to document a worsening LV function, which actually happened in our second case. But once it is getting progressed, you'll be able to document a reduction in LV ejection fraction of less than 50%. So a reduction in LVEF of less than 50% is just a tip of an iceberg, which can be easily noticed in at least 10% of the patient who are undergoing an RV apical pace. Of course, pathophysiology, so you can easily explain the pathophysiology because you are stimulating a muscle for an electrical disease. So, conduction system disease is going to produce either sick sinus syndrome or AV nodal disease, AV block. So for an electrical disease, we are going to stimulate the muscles, and the RV apical pacing is going to engage the nearby LV through myocyte to myocyte activation. So that is going to get slowed down. So because of this abnormal activation, there will be a redistribution of myocardial strain and work that will ultimately lead to increase in fibrosis, myofibrillary disarray, and increase in functional mitral regurgitation, ultimately reducing the cardiac output and LV dysfunction. Of course, Dora sir was discussing about the connection between pacing-induced cardiomyopathy and PVC-induced cardiomyopathy. Of course, you can take all these three groups: LVBV-induced cardiomyopathy, PVC-induced cardiomyopathy, and pacing-induced cardiomyopathy. All these three things, the underlying problem is dysynchronous activation of the left ventricle. So here, the severity of the disease depends on the burden, one, for example, pacing burden and PVC burden. The second thing is the width of the QRS. So wider the QRS, when you have a baseline normal LV function in a patient with a complete heart block, or wider the QRS of duration of the PVCs, you will be having an increase in incidence of a cardiomyopathy in both this group of patients. Of course, underlying risk factors, older patients, male gender, wider intrinsic QRS, all these patients are at risk of developing pacing-induced cardiomyopathy in the near future. And underlying pre-existing atrial arrhythmias, a baseline LV dysfunction EF of less than 50 is always an indication to go for straightaway CRT rather than to go for a simple dual chamber pacemaker. And of course, wider pace QRS. For example, an RV apical pacing is going to produce a QRS of 200 milliseconds. And sometimes we can get a QRS of almost 140 milliseconds in an RV outflow tract pacing, but we don't know whether it is going to give advantage in terms of reduction in the incidence of PIC. But when you reduce the pacing burden, that is going to give a good advantage. So whenever you have a patient with an intermittent complete heart block, so try to make use of this algorithm, implant a device which has an algorithm to reduce this ventricular pacing so that the patient will have lesser incidence of pacing-induced cardiomyopathy. Obviously, prevention is better than cure. So a lot of preventive modalities are available. So one such thing is we already discussed, minimize the ventricular pacing. And second thing, so in a patient where you expect pacing-induced cardiomyopathy to develop, so why can't you straight away go for a CRT implantation? Of course, in a country like India where cost matters a lot, of course, we are not in a state where you can do CRT for all those patients who has a borderline LV function with a complete heart block. But the studies have shown that one particular study, BioPace, which actually included these similar kind of patients, it has actually failed to demonstrate the superiority. But block-HF study, they have shown that a BIV pacing in this group of patients is going to reduce the mortality, heart failure incidence, and a rise in LV end systolic volume index by more than 15%. But when they did a subgroup analysis, they found out that the benefit was primarily driven by this reduction in LV end systolic index. So overall, if you take together this utilization of CRT for those patients with a borderline LV function and an AV block is not going to give big advantages. Of course, still there is a matter of debate whether RV non-apical pacing versus apical pacing is going to have a difference. Trials have consistently shown that there is no significant difference whether you're going to pace the RV apex or mid-septum or outflow tract septum. Of course, treatment part, the current recommendation is to go for a CRT upgradation. And the studies have shown that at least 85% of the patient, they can have an improvement in EF by at least 5%. Remember, it is not normalization, it's just a 5% increase in EF. 85% of the patient can have. And the greatest improvement usually occurs within the first 3 months. Beyond 3 to 6 months, you cannot expect a dramatic improvement. Of course, we know that when you're opening up the pocket for a second time, whether it is for a dislodgement or for an upgradation, the complication rate is going to go up. So with the advent of conduction system pacing, we have now one good solution for treating this group of patients. So in the next 5-10 minutes, I'm going to discuss about the utilization of the conduction system pacing and the role of conduction system pacing in treating this group of patients. So what is the concept? So any conduction system disease producing an AV block can have a disease either in the distal ace bundle or in the proximal left bundle. So if you're going to deploy the lead in the distal ace bundle, just distal to the site of conduction block, or in the proximal left bundle, again distal to the site of block, you'll be able to regenerate a normal appearing QRS. This is almost similar to a surgeon putting a bypass graft for a proximal iliac stenosis, where they'll be just putting a graft just distal to the site of stenosis. Of course, we have two different modalities of conduction system pacing. One is the distal ace bundle or ace bundle pacing, and the second one is the left bundle match pacing. Vijayaraman sir has actually published a lot of articles on utilization of ace bundle pacing as an alternative for CS, cardiac resynchronization therapy. This is one such study which has shown that the ace bundle upgradation for those patients with a chronic RV pacing induced complication has shown dramatic improvement in LV ejection fraction and dramatic reduction in QRS duration. But we know the limitation of ace bundle pacing. We are going to deploy the lead against a membranous septum where just 1 or 2 millimeter of the lead might have gone in. So this will affect the stability of the lead. So in the long run, if you follow up these patients, there's a chance that they can have a rise in threshold. They can go for a lead revision for a probable dislodgement, a high threshold. So these problems can be negotiated by doing what is known as deep septal pacing, or otherwise known as left bundle branch pacing, where I'll be deploying the lead in the proximal septum deep inside, just beneath the LV subendocardium, to capture the broadband fan of left bundle fibers. Remember, doing left bundle branch pacing is much easy rather than confirming the capture of left bundle as opposed to a LV septal pacing. So this confirmation of or differentiation of left bundle pacing versus LV septal pacing is much difficult rather than the actual procedure per se. So a lot of guidelines are available, a lot of criteria are available. For practical purpose, for students, I can say one important thing to look for is the presence of an RBBB conduction delay, which will be manifested as QR in a surface ECG, and demonstrate short and constant R-wave peaking time, or otherwise known as peak left ventricular activation time. And if you have an EP system, show this non-selective to selective capture transition. So if you have a QR pattern in lead V1, and a short and constant LVAT, that confirms you that you have captured the left bundle. So at least these two you remember, and let me describe how to confirm or how to differentiate left bundle branch pacing from LV septal pacing. Of course, the tools available. This is the most commonly utilized tool. There is a deflectable or a non-deflectable sheath from the Medtronic, which is the most commonly used sheath. So deflectable is the one which is most commonly used, is otherwise known as C315H. And the lead is a 4.1 size lead, which is an MRI compatible, and it has an open helix. And the helix is actually the cathode, which measures about 1.8 millimeter. And you can see the radio opaque anodes, which will be separated by almost 9 millimeter from the cathode. Of course, remember, we are entering the LV subendocardium from the RV subendocardium aspect. So you need to know where exactly you'll be deploying the lead. So you have to draw an imaginary line connecting the distal ace bundle to the RV apex, and take your sheath and the lead together. Since it is an open helix lead, take it to the initial 1.5 centimeter. Just pace and see whether you are getting a good W pattern. So still you are on the right side of the septum. Pace the septum, look for a W pattern, and probably a positive QRS in lead 2. So these are the two important things which I always look for: a positive QRS in lead 2 and probably a W pattern in lead V1. Then start deploying the lead turn by turn. Give 1 or 2 turns. Look for impedance. Look for the QRS morphology in lead V1. We'll be having a rise in impedance, and the notch on the lead V1 will gradually ascend up. So at one particular point, there will be a small drop in pacing impedance. Remember, you have to see it in a unipolar configuration. And this small drop of close to 100 to 150 ohms will be associated with a good R wave. So this notch would have formed an R wave. So this is the point where you have to stop. And once you stop, you'll be able to demonstrate the good, beautiful left bundle potential. So the target or probably the endpoint is to get a QR pattern in lead V1 with probably 100 to 150 ohms drop in pacing impedance. So there's a classical Wong's description, but we actually have adapted a different strategy. We will give rapid rotations, and this rapid rotation will generate PVCs. We will monitor these PVCs, and once a PVC with an RBVB delay pattern is appeared, which we actually gave a name as a template beat, we'll stop giving rotation. This is our way of doing. So we have demonstrated that it reduces the fluoroscopic time, it minimizes the myocardial injury. But irrespective of the modality, you have to confirm that you have captured the left bundle, whatever way you are doing, because confirmation of the conduction system capture is very, very important in patients with a cardiomyopathy. So one thing is to look for QR pattern, and second thing is to look for short and constant LVAT, or otherwise known as R wave peaking time. So you have to measure in lead V5 or V6, measure it from the pacing artifact to the peak of R wave in lead V5 or V6. So you have to do it at two different pacing outputs. At 8 output and 2 output is a commonly used output, which we do in our lab. So at both output, you have to show that it is short and constant. There is no absolute number. So though a lot of studies have given some numbers, but there is no absolute number. Some cardiomyopathy patients, they can have even 80 or 90. For example, in our late breaker in 2020, we have taken a cutoff of 90 milliseconds at a cutoff as a cutoff. But Wong has suggested 75 milliseconds for non-LVBV and 85 milliseconds for LVBV. But forget about this number. You have to show that it is short and constant at both high and low output. Of course, capture transition. See, if your lead is right on the top of the left bundle, at high output, it will be capturing both the left bundle as well as the surrounding myocardium. So there will be a non-selective capture. But once you reduce the output at a probably a near threshold output of 0.5 or 0.4, you'll be having a selective capture of left bundle. The surrounding myocardial capture will not occur. So that will produce ECG changes as well as local electrogram changes. So for appreciating this thing, so you need to have an EP system, or even you can use a PSA from the Medtronic or a Senjur rep to look for the local electrogram characteristics. You can see here the QR pattern in lead V1 during non-selective capture has changed to a small r and a large r dash pattern. So otherwise known as a RSR pattern or M pattern. So this change in QRS morphology in lead V1, and you'll be able to appreciate an increase in amplitude of lead S wave. So these two things you'll be able to appreciate in the surface ECG whenever there is a capture transition. And in the local electrogram, we can see both the pacing artifact and the ventricular electrogram are actually crumbled, and this will get separated once you get a selective capture transition. So this is very important thing to appreciate. This is yet another way of confirming left bundle branch capture. Let us see the utilization of this left bundle branch pacing for cardiomyopathy patients. There are certain group of patients where CRT by left bundle branch pacing will be as good as a bi-way pacing. This was demonstrated by Vijayaraman sir et al. In a major late-breaking clinical trial in 2020, where both patients with an LBBB morphology and non-LBBB morphology have shown significant reduction in QRS duration, significant improvement in NYHA functional class, and significant improvement in LV ejection fraction. Similarly, we have analyzed one subset of patients, which is again dyssynchrony related cardiomyopathy, which we labeled it as an LVB-induced cardiomyopathy. So in this group of 13 patients, we could show a normalization of LV ejection fraction in almost all the patients, and the QRS reduction was close to 34%. So this group of patients will always respond to CRT by IV therapy also, but there are certain group of patients where CRT by left bundle pacing may be a little better than IV pacing. So one is RBBB morphology. We know that RBBB morphology are not a good candidate for a CRT by biventricular pacing. So here in left bundle branch pacing, we've shown that it shows significant improvement in LV ejection fraction along with the reduction in QRS duration. Of course, functional mitral regurgitation is going to be a big problem even in patients with the pacing-induced cardiomyopathy. You can have a significant mitral regurgitation because of dysynchronous activation, LV dilatation, and papillary muscle dysfunction. So this left bundle branch pacing, which results in a good electrical resynchronization, is going to remodel the LV back to its original size, thereby reduces the functional mitral regurgitation. So this is one of our case where within 10 days of deployment, we could see how significantly the mitral regurgitation was reduced. Of course, in pediatric populations where CRT by IV pacing is very, very difficult. So this was one kid, a kid from Calcutta for whom RVOT pacing was done. RVOT epicardial pacing was done for a post-op CHP, And within 1 year, the kid landed up with a severe LV dysfunction with an EF of 17%, actually listed for transplant. We had a discussion. We actually thought, why can't we attempt a left bundle branch spacing, though the septum was only 6 millimeter. So it was done as a rescue strategy. So we did it, and we got a beautiful QRS of close to around 9800 milliseconds. And within a period of 2 to 3 months, the baby improved symptomatically, started gaining weight. So this was a 6 months follow-up which I got. The weight had improved from 8 kg to 12.5 kg, and the EF had improved to 31%, and then there were no further episodes of heart failure hospitalization. And the last thing is about a rescue strategy where actually CS lead has failed. So either because of a poor venous anatomy or because of suboptimal lead positioning, the CS or a CRT by IV pacing may not give a good result. So in those cases as well, a left bundle branch pacing is going to give a good, effective outcome. So the advantages being, I can use n number of leads for doing a CRT. I can use a single lead. This particular patient had an AF with an LBBB where AV node was ablated, and dual lead CRT, which is commonly done for all those patients with a non-ischemic DCM LBBB. Triple lead CRT for those patients for whom left bundle could not be corrected by a simple left bundle branch pacing, and quadruple CRT, where you can use a DF1 ICD lead to do a quadruple lead CRT. Coming back to our cases, so this particular patient had simple pacing-induced cardiomyopathy. So the solution is just simple: remove the myocardial pacing lead and put a lead in the left bundle area. So again, the C3830 lead was deployed using a C315 sheet. You can see once the lead was rotated rapidly, you can see PVC started coming, and this has been recorded in our EP system. You can see once a PVC with an RBBB pattern was generated, we stopped giving rotation, and we could confirm the capture by showing the transition. And we tried pacing the distal his bundle to show how the his bundle is going to correct and give a potential. And this is a final ECG. Of course, we have completed the procedure without utilizing a triple chamber BIV device. So this is a post-pacing ECG, and needless to say, within a period of 1 month, his EF has improved. Now he had a middle-lady lesion, which is a straightforward lesion, which needs to be addressed later, probably after a month or so. Coming back to the second case, being a doctor and very apprehensive, previous procedure took a long time, and he had to undergo one more revision on the very next day. So we were a little apprehensive after getting concerned that we'll try 1 or 2 attempts for getting into the left bundle area. If it is not working, his son was very clear, just finish off the PG change and come out. So we thought, why can't we attempt once? So he had a baseline HV block, and luckily for him, the lead went in and we could show all the features of left bundle branch capture. And this is a lead. I didn't extract the whole lead, being an 80-year-old gentleman with almost a 10-year-old lead. I don't want to trouble him much. I just put one more lead. He had some difficulty in, we had some difficulty in crossing the proximal mild stenosed area in the subclavian vein. But luckily we got in, and this is the final case QRS. The QRS duration was around 110 milliseconds. And needless to say, again, once the QRS is normalized with this sort of rapid left ventricular activation time, there were no further episodes of heart failure hospitalization. I started reducing his diuretics. He's scheduled for a follow-up next week. Hopefully, his EF will come back to his original pre-pacing EF of probably 45%. What guidelines says, of course, guidelines, they have endorsed his bundle branch pacing. They have given class 2A recommendation, but for left bundle branch pacing, even the last year's ESC guideline, they have not endorsed it, but they've given that current recommendation will probably need to be revised once more solid evidence of safety and efficacy is published. So we hope that we'll get this left bundle branch pacing in the future guidelines, at least for those patients where you cannot do BIV pacing because of affordability issue. Just a simple algorithm to deal with patients with a conduction system disease when they have a normal EF or abnormal EF. If you are having a patient with a sinus node dysfunction where you hardly expect RV to get paced, probably a simple single chamber or a dual chamber pacemaker, irrespective of the EF, can help. But when you expect that RV is going to get paced for more than 40% of the time, probably you can think of this conduction system pacing rather than doing a simple dual chamber pacing. Thank you very much for your patient listening.
Yeah, thank you, Dr. Shanmuga, for a wonderful presentation. And it's in the ideal world setting, I think all the patients were complete heart block patients who require most of the time RV pacing. I think should go for this either conduction system pacing. but which doesn't happen or is not going to happen very soon. Only centers like yours, probably experts like you, maybe the standard classical form of pacing is obsolete by now. But in most other centers, it is still prevalent. And of course, we hope that these things will improve. Conduction system pacing will become more prevalent in the coming years. But what do you think that having known that assuming that the standard way of pacing will continue for years to come, what is the how do you follow up these patients to pick up earliest possible, cardiomyopathy, so that we can change our decision to convert it to biventricular pacing or conduction system pacing at the earliest stage, so that they don't end up in florid heart failure conditions. How do you follow up? How do you think that these patients should be followed up? By serial echocardiogram or by the molecular analysis like NT-proBNP, or we should wait for the symptomatic status of the patients?
Yeah, that's a very important question. In fact, a practical question, because dealing these patients at an initial stage of their natural history is very easy for us, because the response to whether it's a BIV or a CSP will be much better when you are targeting them at a probably an earlier stage of their natural history, whether it is a pacing-induced cardiomyopathy or an LVP-induced cardiomyopathy. So following them with the biomarkers and all these things will be little much expensive, because you have to spend pro-BNP during every visit. The simple thing is to look for a 6-minute walk test if you feel that the QRS is very broad, or the patient is prone for developing an LV dysfunction, like they have an associated coronary artery disease, they have an associated other risk factors, or the baseline EF is probably in the borderline range 50 to 55. So a practical way is to do a 6-minute walk test at probably 3 monthly or 6 monthly interval to look for reduction in their walking capacity, because we are doing it in the other way. So we usually do 6-minute walk tests for those patients who are undergoing CSP in cardiomyopathy patients. We are following them with an increase in 6-minute walk test duration or a meter distance. So we can use it this way also, like RV pacing patients who are prone to develop instead of using a BNP, and instead of waiting for the EF to come below 50. So once your functional capacity has come down, probably we can advise them or we can prime them for going for an upgradation.
Yeah, I think that is a very cost-effective, almost zero cost kind of strategy. But I think also being echocardiography is not very costly in our country. Probably a 3-monthly or 6-monthly echocardiogram for this patient, at least in the initial stage, because most of the cases of pacing-induced cardiomyopathy, I think, should happen in first month or first year of pacing. Of course, after that also it can happen, but the incidences are little less. But most of the time it happens within the first year of pacing itself. So during this time, a serial echocardiography also probably, especially this might be a kind of an iceberg. The patients should come up with heart failure symptoms, because most of these patients might be already having subclinical heart failure. They may not be having clinical heart failure, but there are evidences of LV dysfunction. If you see the echocardiogram or NT-proBNP, or just a simple rise in the LV filling pressures, cardiac output by echocardiogram. So this is most of the patients actually have these things. Only few patients might be having significant heart failure symptoms later, the later stage. So I think that is a wonderful discussion. And Dr. Ashish, are you there? I think Dr. Ashish might have left. And Dr. Sethi? I don't see him either. Dr. Vadivelu, you have anything to say about this?
Yes, sir. I think conduction system pacing is one of the preventive therapies to prevent pacing-induced cardiomyopathy, because majority of our patients, they undergo pacing for symptomatic bradycardias who require definitely more than 40% of pacing. In our setting, the incidence of incomplete or intermittent complete AV block or patients undergoing for sinus node dysfunction is less common, unlike Western population. Whereas in our setting, it is the frank CHP, this catastrophic CHPs are more common. we ultimately require complete pacing, definitely more than 40-50%. So to our setting, the conduction system pacing, especially left bundle branch pacing, may be more suitable. Rather than only thing we are awaiting the intermediate term follow-up. Like I think we have finished 3.5 years of follow-up. From Chinese, we have 5 years of follow-up. We need some more years of follow-up. Once that is done, then the major guidelines will adopt. Then there will be no inhibition by the majority of the cardiologists.
Yeah, that follow-up is the one which is actually lagging us from implementing it as a day-to-day strategy. So, like few years back, couple of years back, there was a talk about the safety of the lead, burying the lead deep inside the septum. What will happen when you want to extract the lead? So all these questions were there, and these questions are being answered now stage by stage. So Chinese, they have the 5 years follow-up data. So we have close to around the 3.5 years follow-up data, where we could show that again, you have to be very careful. You have to follow the patient very carefully. So there are close to 11% where, 5% where you can have a loss of left bundle capture during follow-up. We had 3 dislodgements out of probably 370, 380 odd cases. And one lead actually entered into the LV on the next day. So all these things you have to keep in mind, and you document everything, whether it is on a positive aspect or a negative aspect, because being a new strategy, it needs a lot of evidence to take it to the next level. And that documentation of both positive and negative thing is very, very important to take this to the next level. But as far as left bundle branch pacing is concerned, there are a lot of positives as compared. You know that medicine is not without any negative things, but the positive things are more than negative things. But the most important, or probably the most salient feature about this left bundle branch pacing is treating a patient with a cardiomyopathy. So you are going to give a dual chamber pacemaker at probably 1/2 or 1/3 of the cost of a CRT PG. And on the long run, probably they will respond much earlier, and you can reduce their pill burden. And many of my patients are getting a simple beta blocker for an EF of 20% before the procedure. So that is going to be a big advantage for our Indian population, where cost is a big constraint.
Yeah, I think absolutely I agree on that. That's why the guidelines are still waiting for the evidences and data to make sure that they don't miss out on the possible complications or long-term results, problems about this conduction system pacing. Within next couple of years, I think the guidelines will be very clear in their statement whether how they are going to accept this modality of the pacing. I think let's hope things are going to settle and improve in future. Thank you very much, the speakers. You did a wonderful job today, and I'm sure all the listeners will definitely benefit from your talks. And thanks, Dr. Navar, for arranging these sessions, and my co-moderator, Dr. Sethi, and all the listeners. Despite a Sunday, you all were present and patiently listening. I'm sure you will be getting a lot of benefit out of this. Of course, half of the Sunday is gone, but I wish a wonderful rest of the Sunday today. And we'll be back again. IHRS will be back next Sunday, same time, with another topic with new speakers. Till then, goodbye.
Thank you, sir. On behalf of LMR Medical College, I'd like to thank Nabha sir and Santosh Vora sir for giving us this opportunity. Have a great Sunday, sir. Thank you. Thank you. Bye-bye.
Yeah.
Thank you.
Thank you. Thank you.
Bye.